So it's a pleasure to be interviewed for the 7th COSTEM meeting. I will just thank the faculty and say that this is our 7th meeting, so almost 15 years, and this is the first in-person hybrids, but in-person meeting after 3 years, so we are all excited, and the meeting is well attended. So I guess that, we started with the most important question in the field of transplant today, and this was CARS versus stem cell transplantation, both for lymphoma and myeloma. As for the second session, my part, it was MRD pre or post-transplant. And usually, a measurable residual disease is the most important prognostic factor in treating today acute myeloid leukemia, also in the conventional treatment, but also in transplantation and post-transplant. And so most of the data indicate a correlation between the relapse rate and the leukemia-free survival and overall survival with pre-transplantation MRD. So patients that are pre-transplant MRD, either by multiparametric flow cytometry or by PCR or by next-generation sequencing, they have higher relapse rate and lower leukemia-free survival, overall survival, and GRFS. So there is no question that pre-transplant MRD dictate transplantation results, and the best proving of this principle is ALL. So the MRD in ALL was studying before in AML, and there we know that with patients that are in MRD negative pre-transplant are doing much better, and actually this lead to a clinical decision. So in patients with MRD positivity pre-transplant for ALL, we are giving Blinatumomab in order to achieve the MRD negativity and then going for transplant. In AML, we don't have yet the means to translate the MRD to clinical decision. So yes, for every patient with high-risk AML, if we can, we give some maintenance therapy, prophylactic or preemptive post-transplant, but usually we give maintenance therapy. And this was the question of the second debate. So should we give more broad spectrum, like Sorafenib, anti-TKI, or more specific? But the answer is that we are giving whatever we can, because not all these drugs are approved in every country. So in our center, we give mainly Sorafenib. It's a question if a hypomethylation agent will help. The meta-analysis show it's helping, but there are other data that don't confirm this. So I think that, MRD, we should measure all along in patient with AML therapy, both pre-transplant, but also post-transplant. And usually, if the patient is MRD post-transplant, he should get anyway some maintenance therapy.